morning, everybody. So my name is Nadia, and my job for the next 15 to 20 minutes is to convince you that spinal cord imaging is a fascinating field. Okay, so here we go. I'm gonna start from the very beginning, right? So when you have a neurological problem, you go see a neurologist, right? So the neurologist, let's say, who can I pick on? Let's say Dr. Banwell. She does her magic, all her neurological examinations, and at this point, she has a pretty good idea on what's going on, right? So then she goes on and orders an MRI of your spine, with or without contrast. And then what the result she gets is hyper signal intensity, C4 to C6. And sometimes that correlates with the clinical functions, the clinical symptoms. Sometimes it doesn't. Sometimes it's negative MRI. Sometimes it takes a while for MRI to actually show a lesion. So what conventional MRI does not tell us is what the focus is of this talk. Okay, so I'm going to share with you a story on how I got involved in the transverse myelitis research. I was actually doing my PhD dissertation in traumatic spinal cord injuries in Philadelphia, and I met an 11-year-old boy who was diagnosed when he was 7. And 4 years later, he came to us because he wanted to participate in our research project. He had notable motor impairment, he had difficulty walking, and so when I scanned him and I compared and I used this technique called diffusion tensor imaging, which I'll explain in a bit, and I compared his data to our controls, healthy controls, he was significantly different from all of them. Compared him to the traumatic injuries, he was also significantly different, so he was somewhere in between. And as part of the study, I was supposed to meet with a radiologist who is blinded to whether this subject is a patient or a control. But his job is to tell me, control, patient. So this guy says, the MRI is negative, this is a control subject. Now, I was an engineering student, and I know we have some engineers in the audience, right? As an engineer, you tend to trust a $5 million MRI scanner over the human radiologist, right? So I didn't believe anything he said, so I went to get a second opinion, right? This time from a much younger radiologist. He also said the MRI is negative. Okay, so I didn't stop there, right? So I waited 2 weeks, went back, and tried to trick them. So I said, hey, I have a new data, a new subject. What do you think of this one? And he says, negative MRI, control subject. Showed him again to the young radiologist. He said the same thing. So in statistics, right, this is what's called inter and intra-rater agreement. And you can't argue with that. So, so finally, we published that. So this is his MRI, right? So no lesion showing on the T2. And this is that technique I mentioned called diffusion tensor imaging also. So we went on to publish that as a case report, and we turned that into a grant application, and we get some money from NIH to do the project. So anyway, so this is how I got involved in transverse myelitis about 5 years ago. Okay, so what MRI doesn't tell us is actually the underlying microstructure of the spinal cord. It doesn't tell us how far the lesion extends. It doesn't tell us what's going on in the tissue above and below the injury. And just because tissue doesn't look it doesn't have that hyper intense signal, doesn't mean that it's healthy, right? So we're looking for ways to assess what's happening in the spinal cord in a quantitative way and assess that tissue that may look healthy on an MRI but actually is not. Okay, so what is diffusion tensor imaging? It's gonna get a little technical for 2 slides, but and I know it's Saturday afternoon, you guys don't wanna hear about science, but just hang in there, okay? So diffusion tensor imaging is MRI based, so it's additional time in the scanner, in that 1.5 Tesla or 3 Tesla scanner. What it does is it measures the movement of water molecules in the spinal cord. We're all made of water molecules, they're moving around. That's actually my failed attempt at drawing an axon and molecules inside of it. And this movement or this diffusion is not the same in all directions, and that we're trying to model that using this technique. And how many people in the audience know what a tensor is? One person, okay. Of course it's you, Dr. Banwell. Okay, so a tensor, I actually didn't know. So a tensor is nothing but a mathematical way to model or represent diffusion. That's all it is. And you guys know MRI is actually three-dimensional, right? So when you take a picture with your phone, you're looking at a two-dimensional image, and it's made of little squares called pixels. In MRI, we're talking about voxels, which is a pixel with a thickness, or a pixel with a volume. So what these geniuses did was find a way to represent diffusion in each voxel of an MRI. Did that make sense? A little bit? Okay, kind of? Okay, cool. So in a spinal cord, this water movement is happening further along the axons than across, and that helps measure by how much they move up and down versus left and right or front to back. And I think this will put it all together very nicely. So this is a cross-sectional image of a spinal cord, and you see how it's made of little cubes, kind of? So each one is a voxel. Each voxel is represented with a tensor, and in each tensor, water is moving in all kinds of directions. And that's what we're measuring with diffusion. It's by how much water moves in each single voxel of an MRI. Okay, did that make sense? It wasn't so bad, right? Okay, perfect. Okay, so if DTI is so fascinating, why isn't it used in the clinic every single day for every single patient? Okay? So DTI is a little bit challenging, okay? This is, especially in the spinal cord. In the brain, I found out actually from Dr. Banwell that it's used in the clinic, but in the spinal cord, it hasn't made it to the clinic yet. Okay. And I went and did a little research to see just how many publications are there for DTI and the brain in the last 10 years. So we have here 5,000, okay? Any guesses for DTI spinal cord? 300, okay. Pediatric spinal cord? Okay, remember your numbers, okay? I have that answer, but at the end. Okay, the pediatric spine is actually, it's a whole different world to image. It's much, much more challenging. And again, like I mentioned, one of the challenges is size, right? The spinal cord is much smaller, and to obtain a certain resolution, you actually have to scan for a longer time. It's also adjacent to the lungs and the heart, so it suffers from all this motion. And also, in pediatrics, kids move, right? And we can't sedate for research, so we just have to say, don't move and hope that they won't. We have an added challenge in pediatrics. So you guys see what the problem is with this image? Okay, so this is a patient we had. He's a QTM patient. I think he was about 9 years old. And you see that big black hole? Okay, that's from his braces. Okay, so we get this a lot from with our pediatric population. The braces are retainers, and his lesion, which is an upper cervical area, was so close to where that signal dropout is. And unfortunately, DTI is even more sensitive to metal than conventional MRI. So I don't think we're going to be including his data for this study. But okay. So for DTI to make it to the clinic, here I have a to-do list for us, for the scientists. We have to improve our imaging protocols. We have to make them standard across all centers. Also, I found out that clinicians love push-button technologies. Right now, it takes me an hour to analyze one data set, one spine. So, and I don't think the clinicians have that much time in their hand, right? So we have to come up with ways to make this automatic for them. Also, hardware improvements. Did you guys hear about FDA approving 7 Tesla scanner very recently? I think it just happened 2 weeks ago. So now we can use 7 Tesla scanners for clinical use. So that means higher resolution, faster scan time. But I know some of our pediatric neuroradiologists are hesitant. They don't want to put the kids in there. But hey, we'll see. And finally, and I think this is the most important part, is we need stronger data. We need these imaging techniques to show or to be able to predict disease severity and monitor how patients respond to treatment. And I think this is the most important part for this to make it to the clinic. Okay. And I think we even have to put the agenda even further and find ways to differentiate between myelin loss versus axonal loss. Everybody's familiar now with what an axon is, what myelin is, but we don't have ways right now to differentiate between the two. Also, I think there's a talk later about remyelination. So the question is, can we use this imaging technique to measure remyelination? So there's a lot to do, certainly more questions than answers. And I added this because this wise man said that if we knew what we were doing, it wouldn't be called research. So it's a lot of questions, a lot of questions. Okay, so now I'm gonna move on to what the study that currently going on at Children's Hospital and how we're trying to answer some of these questions in our pediatric cohort. This is done at the Center for Pain in the Brain. Still fighting with City Hall to add spine somewhere in there, but so we'll see how that goes. So right now, the goal is pretty simple, to develop an imaging protocol that is sensitive to detecting loss of myelin, different stages of the disease, from acute, subacute to chronic. Additionally, define if there's a relationship between these imaging measures and the clinical symptoms and especially pain. A typical study visit, so we're enrolling ages 7 to 21, different stages of myelitis. As I mentioned, 30 patients, 30 matched controls. We match by height, age, and gender, and we match by height because we want to make sure that we're covering the same levels of spinal cord in both groups, and it has been a little bit challenging. We study in TM, NMO, and also AFM. And a typical study visit goes like this. So we do some sensory testing with heat. We test for sensitivity to heat, cold, vibration, what else? Light touch, and other things. And we do this at the dermatome level. You guys know what a dermatome is? No? Some of you? So a dermatome is area on your skin that is connected to your spinal cord level. So for example, someone with a C7 injury, we do all the testing on their middle fingers because that's the area on the skin that's connected to the C7 level. So that's what a dermatome is. On the imaging side, we do the conventional clinical scans in addition to our advanced imaging, and also we scan everybody twice because we want to make sure our techniques are reliable. This is all done in 45 minutes, and then another 45 minutes for the second session. And we're looking at C1 all the way to T12. The thoracic scan takes longer to image because it's longer. On the imaging side, we are testing out these 3 techniques: diffusion, tensor imaging, which you're all experts at by now. Okay, I won't quiz you, but I'm assuming you all know what a tensor is now. Then we're doing magnetization transfer imaging as well, and then myelin water fraction. I will not go in detail about these last 2. And those are images from 1 control subject, 1 patient with TM. That colored map is what DTI looks like. I just added this 2 days ago, actually. And the reason why I added it was just to show you the distribution of so how our patients at Children's Hospital in Boston at the acute phase. And so on the x-axis, we have ages. On the y-axis is number of patients. And we see this clustering, right? 1 around 12 and 1 around 6 months. And the reason why I added this was to show this limitation in our project and how we're only targeting ages 7 to 21. Nobody is looking at the babies, right? So I feel like it would be great to study this younger population as well. We also have a high female prevalence. It's a ratio 2 to 1. And this is, I think, a total of 50 patients. 50 patients. Okay. And, I thought I was the first one to come up here and talk about this at a TMA symposium, but I'm not. This was actually discussed back in 2001 when it was not called RNDS. I think it was called, I can't read small font, I think it was just called Transverse Myelitis Symposium, okay? And diffusion tensor imaging was mentioned in a gathering just like this 16 years ago by this man named Norman Beauchamp. I don't know him personally, but he did say, in the spinal cord, I think we have a shot at diffusion. He even mentioned magnetization transfer, right? And as a technique that has potential in spinal cord imaging. So here I am 16 years later, right? And he had, 10,000 views and 0 thumbs down, so I'm assuming all 10,000 people agreed with what he said. So that's fantastic, right, guys? So I went on and I did a little more research to see if his predictions were right. This is the list of publications, DTI spinal cord, since the beginning of time. Okay, so here. This is when he made his prediction, 2001, okay? And then there was something happened, and then boom, an explosion of publications. Why do you think that happened? Any guesses? I wasn't born, something else. No guesses? Yes. What is it? Nope. 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 Okay, this is when clinical research started. Before that, it was all just theory, what a tensor is, what these techniques are. But this is when all of that started, people started publishing applications. How does this relate to the clinic? This is, in other words, this is when the PhDs and the MDs started hanging out together. Yeah, that's true too, yes. So, okay, so I'm gonna end with this. You remember this? So DTI in brain, we said 5,000 publications. DTI in spinal cord, 300. Any guesses? DTI, spinal cord, and pediatrics. Who says less than 100? Okay, who says less than 50? You can't raise your hand twice. No, okay, wow. We have scientists in the audience, okay. Okay, who says less than 20? 19. Okay, so one more, okay. DTI, pediatric transverse myelitis. Who says less than 5? Okay, looks like this is the glass half empty side. Who says less than 50? Who says less than 100? Okay, all right. 2. 2 publications ever. Okay. So, it's actually good, right? That means we have a lot to do. We have a lot of avenues to innovate, right? We're going to be the first and only, right? Which is, it's pretty cool. I think it's pretty cool. But it's a long way, right, to go from 2 to 5,000. It made it in the brain, and now it's used in the clinic routinely. But I really think I have high hopes for spinal cord imaging. So, okay, so this ends it for me. I just want to acknowledge my team, our neurologists who are fantastic and very patient with me, my funding source. And of course, I would like to thank you all for your attention. I think I may have a minute for questions, maybe not, no? If no, okay, well, my email is right there. Oops, not anymore. Thank you.